Sharon and I both like to talk, so we'll try
Yep.
We'll definitely keep this to an hour. So we'll get started. If people join us along the way, that's great. As I said, if you want to keep your cameras off, if you also have questions along the way, please feel free to put them in the chat if you want, so you don't forget them. Or if you know how to use Teams, you can raise your hand as well, or you can unmute yourself as well, and just feel free to call out any questions along the way. We do obviously have a bit of a presentation to go through, have some Q&A time at the end, but we also sort of are going to run this very conversationally, so happy to kind of go off script and just answer questions as they come up as well. But let me kick off just by firstly welcoming everyone here tonight, and thank you for being here. We know we were just discussing before, sometimes this timing is good, sometimes it's not because everyone's busy, so thank you for taking the time out to join us. My name is Vanessa Tarpon. I am a sex therapist and founder of Authentic Awareness, and I specialise primarily in helping women and couples over 35 revive their sensuality and connection through major life changes, really sort of from that postpartum space right through to sort of post-menopause. I'm going to hand over to Sharon to introduce herself.
Thank you, Vanessa. So good evening, everyone. I'm Sharon Casagalea. I'm a functional medicine practitioner, functional nutritionist, and holistic health coach. And I look after women and men, primarily 40 plus, and women navigating that whole perimenopause and menopause transition. So I look at the root cause of what's going on as it is a change. I look specifically at what's happening to exacerbate some of the symptoms people are experiencing in perimenopause and menopause. I also look at other hormonal issues as well. I'm the founder of Embrace Holistic Health, and I've been running around in this area for the last 2 decades, and predominantly too with a major emphasis on type 2 diabetes.
Sharon, wealth of knowledge behind you. I can't wait to listen to what you're going to say. But today we are talking about why sex and intimacy feel different after 40. And this is one of those topics that people think everyone else, has sorted out, and they're the only ones that are quietly, struggling or worrying about. But if you're here because, sex feels different after 40, or intimacy feels harder, or your body just actually isn't responding either the way that it used to, then you are definitely in the right place, and you are absolutely not alone in this whatsoever. Because a lot of people assume that, if desire drops, or arousal changes, something must be wrong with their relationship, their attraction, or their body. There's something wrong with us. The top complaints that we see from men and women in this age group when it comes to sex and intimacy is low sexual desire, painful sex, difficulty with orgasm, and erectile dysfunction. Those are probably not unknown to you. But in midlife sexuality, it doesn't disappear. Okay, it changes context, and it can be actually a very sexually liberating time for those who are really open to change and exploration, and they're very much 2 different groups of people in the midlife camp. There are those who are really struggling and just don't want to talk about it, and there are those who are absolutely loving life. So you just need to know, obviously, how to adapt and get those learnings that you missed in school sex ed, because we need to talk about what happens to sex and intimacy in relationships as we age. So this session isn't about fixing you, it's about understanding, what's happening, working with your body instead of against it. And Sharon is going to talk us through, what's happening hormonally and physically to our bodies in midlife. And then I'm going to talk a little bit about the psychosocial impacts that are changing intimacy and sexuality. So I'm going to hand over to Sharon first.
Thanks, Vanessa. So what is happening after age 40? And it's common for women and men to also, we say complain, but maybe bring up with their general practitioner or with another health service provider that the hormonal shifts that they're experiencing is impeding on their sexual intimacy. But what is happening in terms of the hormonal shifts is that with progesterone, which is a hormone that we need mainly to keep us calm and steady and our brain happy basically, is that there is such an erratic drop and it has a massive brain effect. At this stage and perimenopause, which is like the years about 8 to 10 years before the last period, is that estrogen is widely fluctuating. So as this is all happening, we get a sudden decline of estrogen. And the main estrogen that keeps us juicy and plump, especially around the vulva, around the vagina area, is estradiol. That's the hormone of estrogen that we need to keep us in our reproductive state. It's a little bit like Mother Nature saying by the time we move into our 40s, and specifically mid to late 40s, saying like you've had your time for reproduction, we're dialing everything down. This will dial down both progesterone and estrogen, but can cause other hormonal imbalances. You'll find testosterone will gradually decline, and testosterone, also being a hormone, is also responsible for libido and a healthy sexual response. But as that gradually goes down, often our stress levels increase. And something that perimenopausal women and menopausal women will complain about is stress being predominant during this time, that they can't balance that, and then the loss of these hormones. That really affects the dopamine and serotonin levels in the brain, the feel-good in the brain, and our oxytocin, which is the feel-good hormone. And those shifts start taking place as landscape of the brain starts to change dramatically. So you're not imagining it if you experience it. So in this context, at this window of life, desire becomes more context dependent. So in your 20s and 30s, you may have got a little bit more sort of, excited quite easily. By this time, you're probably thinking more about your finances, your mortgage, all of those things, even your relationship with your partner, which happens because in this window, relationships can break down, marriage breaks down as that landscape starts to change between, and I'm talking between male and female in this area. And that makes arousal harder. That obviously makes that emotional safety become a real issue because we're relying on that safety net in order to feel that we have reached that sexual intimacy or when we are in that situation. So the hormonal shifts are a huge part of that. In the next slide, can I do that or I don't? Good, thank you. Okay, so 50% of women do mention that they get a reduced natural lubrication that's actually happening as a result of perimenopause and menopause. This affects the vaginal tissue in its thinning. So that estradiol I was talking about that's responsible for the vaginal tissue being nice and thick and juicy is starting to dial down. And that's causing pain a lot of the time for women during sex, and also a slow arousal response. So they may climax a lot later or longer or not because of this issue. We know that GSM, which I'm going to talk about, genitourinary syndrome on the next slide, is one of the major factors that is disrupting those physical changes that is happening at this stage of the lifespan. Pelvic floor changes are another one. That's in people that have had, the endometriosis, or they've had a traumatic birth, It could be adenomyosis as well, which is more intramuscular. We know that pelvic floor physio or doing specific exercises can be, helpful for that. But in that stage of being in hormonal change, it can be quite a significant pain factor for women as well. Sleep is one of the most, or sleep disturbance is one of the most reported issues in menopause for women. I think at the moment in the US, a good 50% of them are leaving their jobs because they're just tired and they're not functioning. If you're tired and fatigued, you don't feel like having sex, you're not feeling intimate, you're not feeling like you can engage in anything. So this physical change, which is a whole part of the perimenopause and menopause transition, is quite disruptive to the whole body. And that can disrupt the overall well-being of the person in this context. The other one is body composition changes. So as women are reaching the perimenopause and menopause stage, they're finding that their body is changing. So they may be putting more weight on around the waist measure. And that's actually contributing to their own body image issues, their confidence, also just how they feel about themselves. If they're not feeling good about themselves, they're not going to have that sexual desire or feel like engaging. So this is a physical change that is quite predominant also in the perimenopause and menopause transition. There are lots more, but for the nature of today's talk, these ones are the most important. So GSM is genitourinary syndrome of menopause. So it's the vaginal dryness, it's burning, it's irritation, it's pain with intercourse, it's recurrent UTIs, urinary tract infections. I see clients and I will say to them, I think you're just suffering GSM, and they will say to me, oh no, I'm not. I'm only, I've only got recurrent UTIs happening. I don't think it's that. When we say it doesn't have to be all of these that are associated, one symptom can come under the umbrella of GSM. So we know it's very common, it's under discussed in the general practice setting. So a lot of GPs don't know what to do with it. They will, if there's bleeding after sex, they may think to take their patient or refer them for, an intravaginal, even having some sort of a scan, or they may look into things like endometriosis, which can happen in perimenopause. It is highly treated, and women don't know that. So it's really undiagnosed, undermanaged, misunderstood. But one of the main issues for women experiencing GSM, because it actually affects their quality of life. I mean, if they're having to stop and pee every 5 minutes, they can't take a bus, they can't take a plane because they're always waiting to go into the toilet. There's that urgency there, and that's a real problem for women, and can affect mental health as well. So it's a real issue. The other thing with this is to really look at your emotional and nervous system factors. Yeah. So we do know at this stage of the lifespan, we do have an increased stress sensitivity. That's thanks to progesterone is reduced significantly. So that reduces the amount of GABA in the brain. And we have a higher cortisol level. Higher cortisol, higher stress produced by the adrenal gland means that there's a lower libido. The anxiety or mood shifts, body image changes, which we were discussed in the previous one, and trauma patterns resurfacing. So we know in perimenopause and menopause that all of a sudden trauma can rear its ugly head. It might not have done so in the 20s or 30s if it's childhood trauma, or whilst you're experiencing it in your 20s and 30s, but as things start to dial down a little and that landscape changes, those patterns of trauma can start to resurface, because that can be something that's really difficult for somebody to navigate at this time. And they might find that there's a greater need for emotional connection. So normally talking to somebody or looking at what the trauma and how to actually deal with the trauma, so cognitive behavioral therapy or other therapies. So it's really important to not only think of low libido or issues with menopause and perimenopause as a hormonal transition or some sort of a deficit or disease. It's not that. It's a transition that totally affects the nervous system and the neurological factors in our emotions as well. So what is treatable for women? So look, all of these are treatable. If you're suffering with low libido, as a functional medicine practitioner, I always go to the root cause of what's going on. A good blood workup is important. So I'd really be looking at all of your hormones. It sometimes can be hard to look at all of those hormones, those sexual hormones, as they do change from a day-to-day basis. But it's a really good idea to get your day 21 checked for your progesterone. You can actually see how far off you are from menopause. But what are the stock standard that I use in my practice is thyroid, iron, and metabolic issues. So I really look at your HbA1c, which is the glycosylation of blood sugars over 3 months. I look at your cholesterol levels, and I really take a good look at inflammatory markers which can cause that oxidation, meaning if we left a bike outside in the rain, it's going to get rusty. And do a full thyroid workup. If your thyroid's not working well, you're not going to produce enough hormones in order for that to help you with your perimenopause and menopause journey. Vaginal dryness and tissue thinning, what I talked about before, so I'll have a look a bit later on a couple of other slides with GSM. Pain with intercourse, and that's frequently associated with women with endometriosis or pelvic inflammatory disease or interstitial cystitis, which can be painful. It's common flares around the vulva and also in the vagina towards the cervix. It is totally treatable, obviously, with the right foods and lifestyle interventions, supplements and herbs. Difficulty reaching orgasm is probably something more Vanessa can elaborate on as well. A slower arousal response and recurrent UTIs. Now, I have an 80-year-old client who still was suffering with UTIs. We're onto it now. She'd suffered for years and years. Look, we looked at her gut. The gut plays a big role in your vaginal ecology. What's happening in the gut is usually what's happening in the vagina terrain or that environment. So really looking at what's happening with the microbiome of the gut and ensuring that we've got healthy bacteria there as well. So all of these are commonly linked to the estrogen and testosterone changes we're experiencing and progesterone as well. Thyroid or iron deficiency, low iron, or someone could have high iron or low ferritin. You might be producing enough iron, but it's not being sent out into the bloodstream as such, transported. It could be unbound or bound iron. Really need to look at that. And working with a functional practitioner to help you to unlock that is really important. Chronic stress and cortisol, so we look at the stress load. Really important to look at how that's impacting the perimenopause and menopause transition. Menopause is something that happens naturally. These things become much louder if we're not looking at the terrain beforehand. Insulin resistance is huge. So if we're walking around with really high blood sugar levels, that's not going to help our perimenopause or menopause journey. It's not going to help our sexual intimacy either. That does wreak havoc on hormonal balance. Pelvic floor dysfunction, and medication side effects. So SSRIs, so anti-anxiety, antidepressant drugs, also antihistamines and antibiotics can all have side effects that are commonly linked to the estrogen deficiency, or we'll say estrogen dialing down rapidly or prematurely for someone that's going into early menopause. So most midlife sexual changes are physiological, they're not personal, and they're highly treatable. You just need to get the right support for them. So common sexual changes in women. So once again, the lower spontaneous desire, the need for longer foreplay. And this has a lot to do with the GSM, the genitourinary syndrome. So women are saying, I'm quite dry down there, I'm not lubricating enough, it's taking me a long time to feel lubricated, sex therefore becomes quite painful. So looking at, and Vanessa explores more of this, looking at lubrication and looking at that need to be more, intimacy just isn't about orgasm, it's about that, that just connection. Women have also said to me that their orgasm feels different to what it was when they were in their 20s and 30s. But I interviewed about 70 women post-menopausal, and they all said that their sex life feels so much better now. So we know that there's estrogen receptors in the vulva, in that area on the outside of your bits, and they have receptor sites. So as these start to dial down, therefore the stimulation might feel a little bit different, and also discomfort without the support. So they're the common sexual changes. So let's not forget our men. Men will, after the age of 40, have a gradual decline in testosterone. They may pick up some more estrogen and become a little bit estrogen dominant, and this is multifactorial. It could be due to environmental toxins. It could be due to their lifestyle, so stress, cigarette, alcohol, being maybe sedentary. The other thing is when their testosterone starts to not dial down as much but become less sort of free, we need to look at a sex hormone binding globulin in their blood test. So an increased amount of that shows that there's less available testosterone. Men are also subject to rising stress levels on a quiet level. They will not present to their general practice hardly or anybody else to talk about this. They will be suffering in silence. Men's health is really under recognized, unfortunately, and it's something we really need to make sure we look at. Rising cortisol levels can contribute to cardiovascular disease, heart disease risk in general, in type 2 diabetes and stroke. So it's so important to look at these hormonal changes in men. So what is treatable? Absolutely reduced libido, a slower erection onset, all of that as well. Their performance overall. We know that looking at their health in general can increase their response to sexual intimacy, and also how they feel about their sexual sort of desire and also embodiment. So as I was saying, really taking note of these physical contributors in men is important. We don't look at this enough. So cardiovascular health, so maybe having a blood workout to have a look at how things are functioning, going to an exercise physiologist if exercise is an issue. Sometimes they can put you on monitors like ECG to have a look at your heart health. Blood sugar dysregulation. So with 1 in 3 people ending up with type 2 diabetes in Victoria specifically, that's a big part of that whole HbA1c. So getting that workup of your blood sugars is important, because that has a lot to do with impotency for some men as well. So that's that really lowered cardiovascular, oxygenated body overall. Abdominal fat is a big one. So the higher the waist measurement, the more that they're at risk of comorbidities such as cardiovascular disease and stroke. Sleep apnea is huge. It's also undiagnosed, so that could be, you think he's just snoring, but is it sleep apnea? And that short-term loss of oxygen to the brain can contribute to andropause as well. So men do go through their own hormonal transition. We go through our perimenopause and menopause, and they go through andropause, and it can be elevated by sleep apnea. It's probably one of the highest leading causes of death in the US at the moment. Alcohol intake is a big one, and nutrient deficiency. So making sure that you're eating well, and making sure you're getting your macros and your micronutrients as well. I think I talk about that again.
Thanks, Sharon. That was great.
Thanks,
so
Vanessa.
Much information, but
all jam-packed into one.
Loved it. Yeah. So I'm just going to touch on some of the psychosocial elements, and yes, we realize this is probably kind of the depressing part, right, of this conversation, where we kind of go through all these things that are working against us when it comes to sex and intimacy, because really there is so much working against us, which is quite frustrating sometimes. But along with all these sort of physical changes, you can very much, and this is both for men and women in this age group, experience an identity shock. And I hear this constantly in my work. I know Sharon, I hear this as well. What's wrong with me? Why don't I want sex anymore? Why can't I get aroused like I used to? Why don't I feel like a sexual person at all? I don't feel sexy at all. And what actually happens is that confidence and that feeling sexy drop first, not the desire. When confidence and central confidence drop, people start, monitoring themselves during sex, and you actually become a spectator during sex, and you start thinking, am I wet enough? Am I hard enough? Do I look okay? Why am I not feeling anything yet? And the moment you start monitoring yourself, your nervous system moves out of pleasure mode and into performance mode, and you start doing what we actually call spectatoring, which makes arousal even harder. Because now you are just in your head, you're worried, right, about how you look, whether your partner feels good, whether you can last long enough, and it's just this vicious cycle that actually exacerbates your concerns rather than helping them. So people start avoiding sex, or they, push themselves through it, and they pretend that they're fine. But none of those really rebuild desire, because if you aren't enjoying yourself, then you don't want to keep doing an activity. I always talk about, having dinner and you go back for seconds for something you really enjoy. Why we don't use that same analogy when it comes to sex sort of astounds me sometimes, because I think, well, why would you keep going back for seconds of sex and thirds and fourths when you don't enjoy it? Now, underpinning all of this is not just, sexual identity, but factors across 5 other domains as well. So I'm not going to go through the biological, because Sharon went through that very well. And then we've got our psychological, which Sharon also touched on as well. So that's the body image shifts, around that abdominal weight gain, increased difficulty with weight loss, loss of sexual identity, stress, trauma, and mental load. Then we've got our relational factors, which can be short or long-term emotional disconnection. And I often see couples who become emotionally disconnected after having children. And now, 10 to 15 years later, as they navigate menopause, that disconnection has never been addressed. It's just lingered quietly in the background, and then all of a sudden it's hit this wall, and menopause becomes kind of the factor that they think is the issue, but this disconnection's been going on for so long. In relation to that is also then partner's health and well-being, infidelity or infidelity concerns, role expectations, and communication issues. Lifestyle changes and work-related changes. We see a lot of people in midlife sort of wanting to either change work, or, as Sharon said, people stop working because they feel tired. They've got to change what they're doing to suit how their body functions. Caring for aging parents, financial stress, or parenting kids and teens. Socioculturally, so this is around our poor sex education and outdated gender roles, and harmful myths, particularly like sex ends at 50, which we all probably have heard at some point over our years. Not for men, they just find a younger version, but for women, you hit 50 and that's it. So, and finally, we've got our contextual stuff. So everything from bad lighting to the thought of, your kids sleeping next door can disrupt your sexual desire. And all of these just cause stress, tension, anxiety, and that puts your body into survival mode and not pressure mode. But with all of this, really what you need is different stimulation, timing, or support. And your mind needs to feel safety and permission. And I am going to hand back now to Sharon, who's going to talk through what's, actually normal versus what's treatable. Because people just assume that they have to live with. This is how things are from now on.
Thanks, Vanessa. Yeah, so what is common in midlife, and this is something that, Vanessa's just touched on as well, some of these areas, is desire becoming more responsive rather than spontaneous. And I mean, in our younger years, we can just spontaneously have sex and just get really intimate and get into the moment without thinking too much about anything. And, you've got your mother's voice in your head. Or if you touch fire, you get burnt. So you're thinking, there's that risk of pregnancy and all those things, but you're still going for it. In that midlife time, we're thinking a little bit more about the context of what we're in, and one thing could be, that the finances or the extra stress, which is common with perimenopause and menopause. So we're being less spontaneous during this stage. Once again, the vaginal dryness, that intensity of our orgasms changing as well. And as our landscape of our brain starts to change and our moods start to change, this significantly impacts libido and how our libido is. So this also can interfere with our interest in sex or how we're feeling about ourselves at the midlife as well. It definitely doesn't finish at 50, and that is the common thought, that we become old and what's the other words, or so many words I come up with last time I did a presentation. It's just that, we are old and you throw us away and we don't have any feelings and we don't have any response. So, that's not true. The fatigue impacting it and body changes as well. So they're really common still at this stage. What I tell my clients, in this phase of the lifespan is I would be investigating persistent painful sex. Because if you've got, maybe you might have a newly diagnosed form of endometriosis happening, could be at age 40, 45 and onwards. So it's not unusual. The same thing as with adenomyosis, which is more intramuscular. Bleeding after intercourse. Now, depending if you're on HRT and you're just newly on a HRT, that could be you've changed your dose and it might be causing the endometrial lining to bleed, is really look at that. If you have tears in the tissue area, like in the example of lichen sclerosis, where in the vulval region, if the tissue is torn, that can increase your risk of STIs. I have a 60-year-old client who's single and thinks now because she she can't have babies, it's okay for her to sort of, have unprotected sex. No, because she's been prone to this tissue tearing. So really look at that. If your dryness and also GSM is not improved after using a lubricant, really look into that further as well, because that could be just the vaginal ecology that you need to, which is the good bacteria, and that can increase your risk of bacterial vaginosis, which is not pleasant. Odor and everything else can be associated with that. Some people can get really distressed and feel quite anxious with the loss of libido because they feel suddenly old. They feel suddenly old that they're not lubricating. They feel suddenly old at perimenopause and menopause already. If the loss of libido is accompanying that, makes things a lot worse. Recurrent UTIs, time and time again, if not treated, can turn into kidney issues, can turn into nasty infections. If you're not looking at it, if you're bleeding constantly from a UTI, really look at what's going on under the hood. It's not pleasant, and that can be fixed and investigated much further. You might need to go for a swab or do a urine test, but really look into that. Pelvic pain's another one. Pelvic inflammatory disease is huge and underdiagnosed. It can be associated with interstitial cystitis, so pain on urination. Have that looked at if that is something that is happening to you, definitely. And then you've got the mental health side. Obviously, that severe anxiety or depression, I would get go and see your practitioner. Get triaged to do a mental health review. Maybe look at some cognitive behavioural therapy, but definitely look into that. Don't live with these things because menopause isn't something that should be dealt with, in this manner. It should be an okay transition, really.
I think that's really important too, Sharon, as you said, that don't just suffer through it.
Yeah.
Because we do still have so many years left
Yes.
to live as well. Like
Absolutely.
we've got a third of life. So yeah, don't just give up on life.
Yeah.
I just wanted to touch on because a couple of times, we talk about lubrication, that comes up all the time as well, and you've touched on it as well. And I just wanted to mention as well that lubrication is the first arousal response to actually happen when the body starts its, physiological changes. When your body, the desire goes, yes, okay, we actually want to do something now. Let's make the body change, make all the changes they need so that sex is comfortable. Lubrication is the first one that actually happens. There are a lot of other changes that the body makes to obviously then make sex and particularly penetration comfortable. But the lubrication as well, depending on how long your sexual activity is going for or how rough it is, won't last that length of time as well, which is also why we talk about lubrication being so important and using lubricant. But it is also a good indicator, I think, as Sharon said, just in terms of, we know lubrication, dries up during menopause, but it is also, I think, a good indication for looking, as we said, at the ecology of the vagina as well, to see if this is a persistent issue for you. What other options are available other than just using lubricant, as you said, as well. I also just wanted to touch on, why we need to recognize sex and intimacy as important in our lives. And I just wanted to call out two of the main benefits. The first being physical and mental health. Sexual pleasure releases all our positive hormones that we talk about, so dopamine, oxytocin, endorphins, and oxytocin actually increases 5-fold during pleasurable sex. So it is a big hit that we get. And we know as well from a lot of research that sexual satisfaction is very strongly linked to well-being. Obviously, with those positive hormones going around our body, right? Everything good is floating around, we feel good. So it is really important to see sexual health as health, and an important part of health, and that can be difficult, especially because in the medical field and with GPs, it's still not necessarily seen as important as physical and mental health, but it is. And we also know that people who are sexually satisfied and believe that sexual satisfaction is important and place an importance on it actually live 5 years longer. So that's not a marketing line for going out and having intimacy. It's actually research backed.
Yes.
For you.
Yep.
The second one is relationship health. So intimacy creates connection. And when sex or physical sex disappears as well, that's when we see shame, guilt, resentment, and rejection start to creep in. And when we see those appear, they erode relationship satisfaction. And as we age, that intimacy and emotional connection becomes really important. And when you do speak with elderly people, they talk very much about the emotional connection and friendship. And that is what they really highlight as, important in longevity and enjoying life as well. But physical intimacy still plays a very important role in that. And I can tell you that there are some very sexually satisfied 80, 90-year-olds going around. And I get really excited when I hear from those people, probably Sharon.
Yes.
As well. And look, their physical intimacy may look different to what we think it might look like. But I can assure you that they are very, very happy with what's going on in their life.
Awesome.
And one of the biggest myths that I do want to challenge tonight is that if desire doesn't feel spontaneous anymore, then it must be gone. And Sharon's already touched on this, that desire is far more responsive. And it does wake up after safety, relaxation, touch, connection, novelty, and reduced pressure. Now, novelty doesn't have to be something extreme either. When I ask people to tell me about the sex that they're having, it always, the shoulders drop, the tone of the voice drops, and it's very clear that the sex that they're having is, boring, mundane, and routine. Novelty for them when they tell me, oh, we're just always in the bedroom, on the bed, missionary position. Nullity could just be changing location, going to a different room in the house, or changing the position from missionary to something else. It doesn't have to be something really extreme, like, you being in this vanilla relationship, and then now, you've got to go into the kink world and head into BDSM. You don't have to go extreme when we talk about nullity. Which means also that if you are waiting to feel horny first before engaging in intimacy, you might be waiting a long time, because that doesn't mean, forcing yourself into sex. It means learning how desire actually works now. And we do also know that a lot of women will go into sex where their desire is not at the peak yet. Their desire is on its way up, but they still need that connection and the physical touch, both the emotional and the physical, to continue to build that desire. But this is where I want to move things a little bit, become a bit more sort of empowering and exciting rather than depressing and us telling you everything that's, impacting you negatively. Because there are always ways to build or rebuild pleasure, confidence, and connection. And I'm going to share with you a few kind of psychological and relational shifts that make a big difference. And then Sharon is going to layer in some very, practical body-based and medical and supplement supports as well that often help at the same time. So, as I said before, desire comes from safety, and this slide just very briefly shows you the real pathway for desire, and it's safety, permission, sensation, interest, which increases the dopamine and all positive hormones, trust, and then desire and confidence. So if you've been waiting to want sex before reconnecting, nothing is wrong with you, as I mentioned earlier. You've just really been taught the wrong order, and we've all been taught that from a very young age. But desire is actually often the result, not the starting point. Often we need the goal to be something that we want to do, something that we enjoy, and then desire will follow. So I just wanted to share with you just 3 very simple but effective activities that you can actually start doing today to move that forward. And the first is positive sexual self-talk. So 1 in 7 women have low sexual self-image. And this is really quite easy to do, again, but a lot of people won't bother doing it. And it's just to stand in front of a mirror naked and tell yourself something great that you see out loud. You can start with your underwear on if you need to, if that's where your comfort level is. But the goal is essentially to just give yourself sexually confident statements whilst running your hands over your body at the same time. Because confidence really starts with self-perception and self-validation. The second one is to really understand your turn-ons and turn-offs or barriers. So identifying what really excites you and what holds you back. As I mentioned just before, when people tell me about the sex that they're having and it's boring, the flip side, my next question will always be, well, what sort of sex do you want to have? And that's when they light up. I do actually have a document that you are more than welcome just to let me know. You can say something in the chat, or you can email me later and I can send it to you. But it's a document that really just helps you unlock, your stimulants and sedatives, and, to have pleasurable sex by making some small manageable adjustments. That's the key to success, is not doing anything extreme. It's those small manageable changes, and that will give you the longevity as well. And the third one is self-pleasure. So exploring your body's sensations is important for everyone at every age, whether you are single or in a relationship. Now you can use your hands, you can use toys, the possibilities are endless. And I have spoken to many menopausal women and in this age group who are a bit nervous starting out because it's either been a while since they've done any self-pleasure, or they haven't done it often. So it's okay to be nervous. Just remember that, you're in control, essentially. No one is there to judge you. This is you on your own. No one's watching you. But self-pleasure is also important in relationships too. We have this social idea that, you don't do it once you're in a relationship. But that is absolutely false. What it actually is that more so men are still doing it, but they're just hiding it behind closed doors. But it is still important, and it's important for everyone. And the desire for self-pleasure, and I think this is where the concern comes in, that the desire for self-pleasure will mean that you actually no longer have desire for your partner. That is actually incorrect. Though the desire for self-pleasure or your partner actually work together, not against each other. And on the flip side, if you are single and you're wanting to date, this is a great way to really keep yourself active and rebuild your self-confidence as well, and your communication, and know what you like, know what you enjoy, and know what you are willing to ask for as well. But for those in a relationship, I also just wanted to give two other points. The best thing for a relationship as well, if you are really quite disconnected and you just don't know how to resolve it, is very much to go back to basics. Open communication being the most essential is really important for getting onto the same page. So having open and honest conversations about expectations, needs, boundaries, regularly check in with each other, during and after sex as well. And one of the easiest and most important pieces of communication that people, again, often forget about because it just falls off the radar, is to give your partner one daily appreciation message. It just lets them know, and when they give it to you, it just lets you know that there is that connection and they are grateful for you and thankful for you. And that message can be about anything at all. It can be, thanks for getting the milk without me asking you to have to go and get more milk because you noticed that we had run out. It doesn't need to be anything excessive. But it's very easy for us to think we're grateful for a partner, but forget to share those thoughts. But when you do share them, you will feel that immediate closeness, because that your partner will automatically go, oh, thanks, like you actually saw me. And finally, prioritizing connection. So schedule in sexual and non-sexual times. Everyone always thinks, oh, scheduling, that's not sexy. It actually is, because the anticipation of the build-up of, something's coming. One, you can actually prioritize your time, and if you've got chores to do, okay, I'm not going to do them on Thursday because that's our scheduled sexual time, so I'll make sure I do these things on Wednesday, get myself prepared so you can be relaxed and comfortable. But also the non-sexual activities are really important as well. So they're things like dates, or sharing new activities. And there is research as well in terms of the being more beneficial where you share a new activity together, as opposed to just sharing sort of a common activity that you regularly do. And also 10-second hugs.
Oh, yeah.
And love that one.
Love that.
Yeah. People will be surprised when you actually give yourself 10 seconds or longer to relax into that hug, how much of the positive hormones are released and how much your body actually relaxes rather than just a quick tap on the back. And all of that, leads to closeness and can also unintentionally lead to more sexual interactions, those non-sexual ones. But great sex in long-term relationships comes from communication and prioritizing each other and your, physical and emotional intimacy as well. And just before I hand back to Sharon, I do just want to go through a couple of sort of additional recommendations here in terms of sort of product or support that is available. So I do stock a product called Owner, which is a set of 4 rings that actually act as a buffer, and they're really useful for penetrative intercourse to stop pain. So if depth causes you pain, this can be enough to stop the penis or object going in so far. If you find that your partner's hitting your cervix, or if you have prolapse and you're wearing a pessary, a lot of women will actually take their pessary out during sex, and it's not actually because they want to take it out, it's because their partner complains that they can feel it. This can be potentially enough of a buffer that you can keep it in, and your partner won't feel it as well. Then, of course, we have our lubricant. So, as Sharon said, vagina dryness, lack of lubrication, one of the biggest barriers. Once we hit 40, we live by the motto, lube is life. And there are lots of lubricants on the market. So it can make it really hard to decide, which one to buy. The best advice that I can give you is to find a high quality lubricant, and unfortunately we don't generally stock those ones in the supermarkets or many chemists. Some chemists do. The better quality ones tend to be found online. There are also various different types. I always tell generally women to start with a water-based lubricant because it's just the most versatile. They can be used in any situation, with all types of condoms, safe with sex toys. So my preferred are Alchemy, who also can put some vaginal estrogen into it if you like. They are actually Melbourne-based gynecologists, and you get a 15-minute consultation with them after you make the purchase, so they will actually compound it for you to suit you. Lucy Lube or Yes Organics. Then there's the silicone-based, which are thicker than water-based, so they do last longer, but they can't be used with silicone toys. So if you have a history of pain, these are good. And you can also use them sort of in the shower or bath. Uber Lube is a good one there. Or there's our oil-based lubricants, which are, considered generally edible, safe for the vagina, can sometimes be messy or stain sheets, or could irritate the skin, can't be used with latex condoms. So the two there are Yes Organics or Olive and Bee. Your lubricant is very much a trial and error, find what suits your body best.
Absolutely.
And I do just want to call out very quickly too that a lubricant is different to a vaginal moisturizer. You may still need a vaginal moisturizer for during the day for sort of activities to make yourself more comfortable. A lubricant is only for sexual activity. Sex toys, just very quickly again, there is no reason why people at any age can't use sex toys to enhance desire and experiences. And I say enhance because generally, let's say for instance with a vibrator, these things are enhancing your arousal and desire, so your responses are becoming much faster. That's not actually your body's natural arousal time. These are speeding things up for you. Lots of options on the market for all sorts of different needs, from vibrators to cock rings to positioning aids like the pillows and things that can help your comfort. Also think about what will make you feel comfortable. So is it wearing lingerie or a wig? Anything that makes you feel good in yourself will make you stay present and enjoy the experience more. Plenty of options. You're more than welcome to contact me after if you want some specific recommendations on anything. And finally, just seeking advice from a professional is a sign of strength. It's not a sign of weakness. And this is essentially what sex therapists can help you with. So concerns about sexual functioning, relationship concerns, physical concerns, or maybe you just want some advice on how to spice things up. But I'm going to hand back to Sharon, who's going to give us some information on physical and sort of hormonal supplement supports as well.
Thanks, Vanessa. That was awesome. So look, it's individualized and really depends on the person. So a lot of the time, women don't want to go down the pathway, especially for GSM or dryness and tissue health, of that sort of estrogen, MHT, HRT. So I will support both. My goal is to look at making sure that the tissue is well lubricated, that there is a great barrier from infections, that there's obviously a really good vaginal microbiome happening. So when I look at clients who come from many different areas, they may have estrogen positive cancers. Some of these are not going to be helpful. Are you there?